Thank you. Thank you. Good afternoon and welcome to this briefing for the Health and Government Operations Committee. This is our first session back in person since 2020, and so I ask for your patience and we encounter some technical streaming issues. This briefing is being streamed on the Maryland General Assembly YouTube channel. Panelists will control the transition of the slides. Before this briefing, all members were emailed a copy of each presentation. If you do not have these documents, please let the committee staff know and we will send you a copy. Please adhere to our usual committee rules of one question and one answer from the panel, not one question and one answer from each panelist. Please keep your questions brief. Please keep in mind that this briefing is scheduled to conclude before 3 p.m. Immediately following this briefing, we have a bill hearing. At the conclusion of this briefing, I will announce a short break and the start time of the bill hearing. And the reason is because staff needs time to start a new Zoom, a new link for YouTube. Today, the House Health and Government Operations Committee will hear briefings from the Maryland Healthcare Commission on telehealth and the Certificate of Need Health Planning process. We will begin today with Mr. Ben Steffen, who is the Executive Director of the Maryland Healthcare Commission. Mr. Steffen, come up. And good afternoon. How are you?
Very well. Fair opinion, Melanie. So, if I can I also invite my
yes.
colleagues up?
Whoever you have on your panel, please come in. I see David. Wonderful.
Yes,
and Paul?
That's correct.
How are you?
So thank you, Chair Pinion Melnick, members of the committee. Again, for the record, Ben Steffen, Executive Director. What I'm going to do is provide a preview and overview of the Healthcare Commission's responsibilities, and then I will pass it on to David Sharp, who will overview our telehealth recommendations required under House Bill 123, passed in 2021, and then Paul will provide a briefing on the CON process, a process that I know most members have heard a little bit about, but probably a complete overview. Not as many people have heard how this all works. So David, if you can move to the first slide. I did this same presentation in the Senate and used 20 minutes. My colleagues said that was too long, so I'm going to be fairly quick in terms of the overview because I know many of you have heard some of this at least once before. The Healthcare Commission has a very broad vision, and I think when you consider responsibilities that the legislature has given us, it reflects the fact that the vision is very broad. It focuses on promoting informed decision-making, increasing the accountability of the healthcare system, and improving access, recognizing that we are in a rapidly transforming healthcare system as a result of changes that have been brought on both operationally and as a result of federal government decision-making over the last decade. We are organized according to the systems that we evaluate and regulate. We have 4 centers, the Health Planning, Facility Planning and Development Group, headed up by Paul Parker, focuses on health planning and CON, as the title would suggest. David Sharp, on my right, heads up the Center for Health Information Technology and Innovative Care Delivery. Our Center for Analysis and Information Systems, headed by Ken Yates-Trotman, focuses on the assembling of large clinical data systems and policy reports using those data. And Teresa Lee leads our quality measurement and reporting efforts, and many of you have probably seen our quality reporting website, Maryland Quality Reports, or our more what I would characterize as a more aggressive site that focuses on price transparency, operating under the title Where the Cost. David, if you could jump to the next slide. Consistent with our roles, we typically get all of these. We plan for health facility development. We measure and aggregate cost and quality data. We really focus on enabling technology innovation. We're we're a convener, and at the present time, we have probably a half dozen different work groups under operation, some of which directed by the legislature, others required under our statute, and others simply staff imagination on what could be done to make the healthcare system work more efficiently. And lastly, although we are an executive branch entity, administratively part of the Department of Health, we are also seen by the legislature as somewhat of your policy arm, and it's not uncommon in any session for the Healthcare Commission to get 3, 4, 5 requests from the legislature to conduct studies over the recess. I just want to highlight a few things that we've done over the last 4 years that really really flagged the priorities we established in 2019. We do this every 4 years, and we're about to refresh those priorities. A report, after approved by our 15-member commission, will be shared with the legislature. The current priorities focus on educating and engaging the healthcare community on our activities and our roles within the healthcare system, to make and continue to improve the recognition of MHCC as a trusted source of quality and cost information, recognizing on the internet today there's a ton of organizations that do present cost and quality information all the way from Yelp to the federal government. But we think Maryland Healthcare Commission has a unique place in Maryland in picking best of breed information collected by our colleagues in the federal government and other state agencies, as well as developing ourselves and really showing only information that we believe is trustworthy and reliable in terms of quality. Of course, you'll hear more about the CON program momentarily, and we work very closely with HSCRC and the department in fostering the development of value-based payment models. The most direct activity currently is focusing on primary care. And then lastly, we seek to expand the use of telehealth services. I want to remind the committee that this was a priority in 2019, prescient, if you will, given the events of 2020 and beyond, where we went from 2 to 3% use of telehealth to at one time in 2020, 50 to 60% of all healthcare services provided by healthcare practitioners were delivered through telehealth. That's slowed down, but we know that it's going to be an important priority moving forward. As I said, our 2023 through 2026 priorities will be released momentarily, and I just want to highlight that we will be pivoting to focus directly in the priorities in greater emphasis on health equity and social determinants of health. This report will also focus on setting some milestones, some objectives and milestones so we can measure ourselves against our priorities going forward. I do want to highlight 3 or 4 different areas of our priorities in terms of what we have done recently, focusing first off on our responsibility to convene and engage stakeholders. In here in 2022, we have a pretty impressive list of activities that have been underway, launched, and completed, or launched and underway. They focus on primary care, health worker workplace violence, the promotion of two-sided risk programs, including the responsibility the legislature gave us to actually measure the efficiency and effectiveness of the two-sided risk programs that for the first time in 2022 the legislature authorized payers to undertake. We're also looking at the broadened swing of healthcare, particularly as it's delivered in small assisted living facilities, and we are working with the hospice network, nursing homes, and hospitals in further clarifying the delivery of palliative care in the state.
May I ask you, if I may respectfully interrupt you for a second? Will
Sure.
you be so kind as you discuss these bills? We have 7 new members, and just tell them a little more about the bill if you can.
Sure.
Thank you so much.
Sure. So I'll kind of focus on two or three that I think are very important and long-lasting.
Thank you.
The primary care investment legislation directs the Commission to work with a stakeholder group to develop perhaps funding levels or thresholds for primary care. Approximately 10 states have set in either through their statutory changes or through policy changes how much of the insurance premium should be dedicated to primary care. We have not done that yet, but it is the intent of the legislature that we come forward with a report recommending our approach for moving forward. I think this is especially important as we move into the next phase of the model to recognize the key role that primary care plays in these initiatives. We all recognize that more needs to be done, and we're going to be looking at and coming back to you with the recommendations on whether we should set a certain level of spending that would be dedicated to primary care. An important initiative, certainly. In terms of the measuring the impact of two-sided risk, that was a piece of legislation that was passed last year. I actually don't have the right bill number there, I just noticed, but it sometimes operates under the title, the Care First bill, that enabled insurance companies for the first time to offer programs to providers, principally healthcare practitioners, doctors, and other professionals, programs in which there was upside risk, which has long been available, but also incentives in which there was also the potential that if a practice did not perform according to the requirements under the program, the fact that funds could be reduced if performance was not satisfactory. This is something that has been available in most other states, but had not until last year been something that had been permitted under the Maryland insurance statute. Our role is to assess the effectiveness of these programs. It's just getting underway. We believe that the role that the legislature took to, if you will, authorize this, and the responsibility we are given to really come back to you and say, do these programs work? Are they really effective in all types of provider environments, i.e. does it work for large health system-owned practices as well as small practices? We think there are some particular challenges with smaller practices, and we hope to provide some insight not only to the legislature, but to the payers in terms of how these are being rolled out and how effective they are. Another area that I want to highlight is the oversight of small assisted living facilities. We have about 1,500 assisted living facilities in Maryland. About 300 are facilities of 10 beds or more. The remaining 1,200 or so are small. You probably are going to see those as you drive through some of the residential areas in your own communities. And the concern has been, what's the appropriate regulatory regime for smaller assisted living facilities, given the resources that they have to devote to care delivery? What sort of responsibilities do we have to fairly evaluate effectiveness and quality of those smaller facilities vis-a-vis large corporate-owned assisted living, which are quite plentiful and well-known, but really are not the only option for individuals here in the state, that small facilities, in particular for people who have financial challenges, may be the best alternative available to them as opposed to home care. That report will be submitted to the legislature coming this December. Lastly, a host of initiatives focusing on public health. We have developed themes related to the evolution of our Health Information Exchange, which is an information hub that provides for the collection and transfer of largely clinical information. Over the course of the last 3 years, as the pandemic wreaked havoc on the healthcare system and demonstrated that there are significant gaps in the public health infrastructure, the Health Information Exchange in Maryland, CRISP, did significant expansions in the services they provided. The Healthcare Commission worked hand in hand with them. But we also recognize moving forward there are increasing challenges related to how CRISP as a private entity integrates with state agencies, as well as the key concerns related to privacy and security as this information becomes more broadly and appropriately available, but also increases consumers' concerns about how information pertaining to their health is used. We have developed a concept called the Health Data Utility in collaboration with other organizations interested in the promotion of health technology, and look forward in a future presentation to talk about how we see a health data utility rolling out in Maryland. And lastly, I don't see Delegate Cullison, but I want to recognize the work she did. We are moving forward with rolling out requirements passed last year that provide direction to payers and health systems to make advanced care planning information more easily accessible and more widely advertised. Clearly, it's not the first thing we think about typically. And especially if we're not ill, it's something that we don't think is important, but increasingly expressing your wishes, even if you are a healthy person not expecting severe illness to overcome you, you need to have plans put in place. The payers are working to do that through providing information on their websites. We are working with CRISP to align information that they present so we can point to a standalone advanced directive repository, and we think this is a multi-year effort. It's not, as I said, something that everyone wants to do, but we all need to do it. If we can move to the next slide then. In terms of the reports that we released and consistent with the chair's request, just briefly highlight some of the reports that have been released over the last 6 months. They include a couple focusing on actuarial estimates on potential mandates that were not adopted last year. If a mandate is not adopted, the chair of HGO or Senate Finance may request that MHCC conduct a assessment of the economic, medical, social impacts of adopting this mandate. We did 3 of those this year. The coverage of home health test kits, I know that was considered but not passed. It's back. It's back as a proposal, I believe. We also worked with the department on health worker workplace violence. That report was released just later last month. We also, as I mentioned, talked about health data utilities. We also examined, as a result of requirements in the budget reconciliation bill, the policies that organ transplant providers use in building their recipient list. The legislature was concerned that patients of lesser financial means were not getting on that list. We concluded, based on the information we gathered, that that was not the case, but we believe ongoing data needs to be gathered on how these lists are continue to be populated, and we need to continue to monitor the availability of transplants to all members of the Maryland population. An ongoing update. I know this is an issue that is being discussed this year. We released our trauma services report, which discusses the flow of revenue through the Maryland Trauma Physicians Services Fund, established more than 2 decades ago. Trauma policy in Maryland needs to be refreshed, and we're looking forward to working with the legislature and others in upcoming recesses to consider what the options are, and would look forward to coming forward with recommendations that could potentially lead to statutory changes in 2024. And lastly, a couple other mandate studies, one on expanding in vitro fertilization, and finally, one issue that I think was discussed fairly intensively, the focus on expanding cost sharing or limiting cost sharing for physical therapy, holding that on par with primary care. We don't think the idea of making physical therapy on par with primary care makes a lot of sense, but certainly adjusting cost sharing does. The fact is that physical therapy is often an ongoing treatment, and many policies do require currently $25 to $50 per physical therapy session, which for many consumers is excessive, and consequently they do not receive that care, in some instances seeking other types of treatment, medication, for example, that have longer-term, more deleterious consequences on their health than physical therapy. So what I would say is parity along with other services, but we think particularly as primary care is so essential, to try to make it, any service on par with primary care is not advisable, although we think adjustments may be credible. I'll pause here. I do have colleagues here who are very anxious to present, but if there are questions, happy to take those.
Why don't we allow your colleagues to present, and then afterwards we will open it up for question. Would that be okay?
That would be perfect.
Wonderful, and thank you for being with us today. Who will be next? Wonderful, David. You want to introduce yourself to the committee?
Sure. Good afternoon, Madam Chair, members of the committee. My name is David Sharp. I'm the Director for the Center of Health Information Technology and Innovative Care Delivery at the Maryland Healthcare Commission.
Move your microphone. Yeah.
And
Thank you, David.
And it is an honor to be here before you today to talk a little bit about the telehealth study over the last couple of years. So I'll proceed. I'm multitasking with different fingers here. And right. Okay, next slide, please. So
He'll pay you later.
Again, good afternoon. Telehealth has come a long way since 1964, when providers at the University of Nebraska established a two-way television setup linked with a state hospital to perform video consultations. Fast forward to 2020, where executive orders issued in response to the COVID-19 pandemic pushed telehealth to the forefront in care delivery. Payers rapidly expanded telehealth coverage, diffusion among providers occurred quickly, and consumer adoption skyrocketed. Post-COVID-19 public health emergency, stakeholders recognized that telehealth should remain a feature of care delivery. The Preserve Telehealth Access Act of 2021 maintains the existing coverage and reimbursement established during the COVID-19 public health emergency, and requires MHCC to study the impact of telehealth as it relates to the use of audio-only and audiovisual technologies in somatic and behavioral health interventions. The study yielded 15 recommendations as it relates to telehealth coverage, technology, payment levels, and future study in terms in statute and network adequacy. Next slide, please. This slide provides an overview of the work and engagement of stakeholders. Over 1,000 responses to a provider survey, 78 structured interviews with English and Spanish-speaking Maryland consumers, 2 focus group sessions with behavioral health care subject matter experts and providers and consumer organizations, A telehealth claims analysis using Medicaid, Medicare, and commercial claims, a literature review that examined the impact of telehealth on access, utilization, and cost, and 2 town hall events with payers and providers. Next slide, please. Okay. Stakeholders were notified about a web page where routine updates would be posted throughout the study. We invited stakeholders to subscribe to receive push notifications. About 45 stakeholders, which is a blend of individuals and organizations, subscribed to the web page. Next slide. And next slide. Okay, so I'll begin talking about the recommendations. As I noted, there are 15 of them, and a little orientation to the slide. I'll step through the recommendations, but the bullet points that trail beneath each item represents snippets of rationale. For a more in-depth review of the rationale that supports the recommendation, I would refer everyone to the published report that was sent to the General Assembly at the beginning of January. For our first recommendation, continue to allow use of telehealth by any healthcare provider licensed, certified, or otherwise authorized under the Health Occupation article to provide healthcare in the ordinary course of business or practice of a profession or an approved education or training program, or for interprofessional consultation. Allow a healthcare provider capable of providing telehealth services using audiovisual technology to deliver services using audio-only technology. Allow use of audio-only for somatic care in the event of audiovisual technology failure, or at the clinical discretion of a treating healthcare provider, requested by the patient, without requiring documentation in a clinical record. Allow unrestricted use of audio-only for behavioral health based on patient consent to receive care via audio-only technology.
And just to interrupt, David, we'll probably circle back. That's one of the most sensitive and debated recommendations in the report. So want to be sure everyone's clear on our recommendation. Go ahead,
Okay,
David.
next slide, please. Allow healthcare providers using remote patient monitoring to obtain consent at the time services are initiated for new and established patients. Allow remote patient monitoring technologies to minimally collect 2 days of data over a 30-day period. Allow a healthcare provider to use telehealth to provide hospice care services consistent with their profession standard of care to patients in a facility or at home. Next slide. Allow telehealth services to be furnished in a hospital inpatient setting and in a nursing home setting. Require a minimum of at least 1 in-person visit by a treating physician 24 hours following a telehealth hospital inpatient encounter. Require 1 in-person visit by a treating physician at least once every 30 days for the first 90 days after admission and at least every 60 days thereafter in a nursing home setting. Require healthcare providers to utilize communication technology that complies with privacy and security requirements established by the Office for Civil Rights at the U.S. Department of Health and Human Services to qualify as a distant site. Continue payment levels for telehealth services relative to in-person care for 24 months. Require MHCC to study payment parity for audiovisual and audio-only technology and submit a report to the Maryland General Assembly by December 1st, 2024 that addresses the following. Does it cost more or less for providers to deliver telehealth? Does telehealth require more or less clinical effort for a provider? Are there aspects of telehealth that yield lower value, overuse, or conversely greater value that inform the debate on payment parity? The adequacy of reimbursement for behavioral health care services delivered in person by telehealth and any other findings or recommendations by the study. Next slide. So we're moving on to the terms and the clarification of them. I would call your attention to the item listed below the title. I want to point out that the proposed language on the terms to be clarified are only intended to clarify and not replace select terms in statute. So I'll go through these. Behavioral health includes mental health and substance use conditions, life stressors and crisis, stress-related physical symptoms, and behavioral health. Communication technology-based services includes a variety of non-face-to-face patient communications, such as two-way audio-only, telephone interactions, remote evaluation of patient videos and images, virtual check-ins, e-visits, and remote patient monitoring. Established patient means an individual who receives professional health services from a provider or another provider who belongs to the same group practice within the previous 3 years. Telehealth consent means affirmation received prior to or upon initiation of a telehealth encounter from the patient, family member, or caregiver for an audio, video, or audio-only encounter and documented in the patient record. Telehealth includes the delivery of medically necessary somatic, dental, or behavioral health services to a patient at an originating site by a distant provider through communication technology. That includes the use of audio-visual or audio-only technology to permit real-time interactive communications. Next slide. And next slide. So we're moving on to the part of the study that was completed by the Maryland Insurance Administration. Here I will present on their recommendations, which there are 3. Okay, the first recommendation, we'll just jump ahead. The first recommendation, allow the MIA to retain the latitude currently granted by the legislature in the insurance article, which states, in adopting the regulations, the commissioner may take into consideration other healthcare services delivery options, including telemedicine, telehealth. Consider whether to permanently codify telehealth coverage expansions for health benefit plans into law. And their, next slide please, and their last recommendation, consider whether to codify additional prohibitions on telehealth only benefits or telehealth first benefits for health benefit plans into state law. So that concludes my presentation on the recommendations from the telehealth study, and at your pleasure, I'm happy to answer any questions.
Who's next? Paul?
Thank you, Madam Chairman, members of the committee. I'm going to give you a brief overview of the Certificate of Need program, what it regulates, and how it regulates healthcare facilities. I want to stress that this is very brief. The Certificate of Need program has been in place for almost 50 years. So the statute has been amended many times, changing the scope and process of CON regulation. So I like to tell my staff that if you look at the COMAR regulations, the regulations defining the scope of CON are only about a third as long as the section of the regulations that defines exceptions, caveats, and other types of nuance to CON regulations. So just keep in mind that this is pretty high level. CON regulation primarily involves the review and approval or disapproval of healthcare facility capital expenditures. We also regulate introduction of certain types of services that may or may not involve capital expenditures. Generally, what the Commission is looking at in making decisions on these projects is the need for the project, whether it is a cost-effective alternative for meeting needs, whether the project is viable, and whether it has an acceptable impact on cost and charges and the existing healthcare delivery system. And the other criteria that's important here is the Maryland State Health Plan. These are regulations that address the review of specific categories of project. The State Health Plan currently consists of 15 chapters of regulation that address different categories of healthcare facility project. And Certificate of Need regulation it currently exists in various forms in about 35 states. The types of healthcare facilities regulated under CON are hospitals, that's both general hospitals and special hospitals, freestanding medical facilities, which would be more accurately called freestanding emergency centers. These are facilities that are developed and operated by general hospitals, essentially as satellite emergency departments. Nursing homes, residential treatment centers, which are behavioral health facilities for adolescents and children, larger ambulatory surgical facilities, and by that, we're talking about 3 or more sterile operating rooms. Under that size, you do not require a CON to establish an ambulatory surgical center. Alcoholism and drug abuse intermediate care facilities. This is one type of addictions treatment facility, and it's fairly high level. It's just below hospital level care. It's characterized by the American Society for Addictions Medicine as intense, medically monitored, intense inpatient care facilities. Home health agencies and general hospices. The specific services that are categorically regulated under CON are medical rehabilitation, neonatal intensive care, cardiac surgery, percutaneous coronary intervention, which some people know as angioplasty, organ transplantation, and burn intensive care. Next slide. Okay. So when does a healthcare facility need a CON? You need a CON to establish a new healthcare facility, to relocate a healthcare facility, to change the bed capacity or operating room capacity of a facility, to introduce certain new services that we just reviewed, and to make a hospital capital expenditure of the lesser of $50 million or 25% of the hospital's budgeted revenue. This is, I want to note that this is a requirement that can be avoided by hospitals if they agree to what is called take the pledge, which means that they're not going to require any sort of capital-related adjustment to their revenue that exceeds $1.5 million over the life of the project, which is a very kind of negligible adjustment. CON regulates some non-institutional healthcare facilities, home health agencies, and hospices. So for these healthcare facilities, the primary way in which CON regulates them is it requires them to seek approval to serve specific jurisdictions. So essentially, we're regulating the authorized service areas for these types of facilities. So in 2018, the Commission issued a report on modernization of the Maryland CON program, which recommended changes in the scope of CON and other aspects of regulation. And there has been some changes in the statute related to that modernization report. We eliminated capital expenditure thresholds as a basis for requiring a CON for all healthcare facilities we regulate other than hospitals. So there used to be actual expenditure thresholds for all the categories of facility we regulate. We eliminated the need for CON approval to add beds at the alcoholism and drug abuse ICFs and also by hospices. We increased the capital expenditure threshold for hospital CON from approximately $16 million to, as I noted previously, the lesser of $50 million or 25% of global budget revenue. And I want to note that this is consistent with rate review thresholds, which were adopted at the same time by HSCRC. So we're now aligned in that respect. We redefined CON-regulated ambulatory surgical facilities as facilities with 3 or more operating rooms. For many years, that limit was 2 operating rooms. We eliminated the requirement that hospitals obtain a CON for any increase in operating room capacity in any setting. So hospitals are now on the same level playing field with any other person in that they can develop smaller ambulatory surgical facilities off of the hospital campus without a CON. And we established deemed approval for most CON reviews not completed within 120 days of docketing. Next. Other recent accomplishments, we've updated 7 chapters of the state health plan in the last 5 years, and we list those there in that first bullet point. We've adopted new regulations that add performance, character, and fitness standards for persons seeking to establish a new nursing home or home health agency, or to add beds at nursing homes or expand the service area of a home health agency. We've authorized hospitals to establish 5 new freestanding medical facilities, again, freestanding emergency centers, that replace general hospitals in Laurel, Cambridge, Havre de Grace, Baltimore City, and Crisfield. And those are all operational freestanding medical facilities, with the exception of the facility replacing Harford Memorial Hospital. And that's a campus that's under development in Aberdeen. We worked with HSCRC to develop more standardized and coordinated assessment of the financial feasibility of capital projects. And we implemented the first rounds of an ongoing performance review process for cardiac surgery and PCI programs in Maryland. This was established about 10 years ago, and we've now completed our first round of ongoing performance reviews for all the cardiac surgery and PCI programs in Maryland. And this is aimed at making sure that these services are being provided appropriately and at an acceptable standard of care. So we look at outcomes and process measures. Other things underway, we're undertaking a comprehensive update of our procedural regulations. We've had one round of informal review and comment. We're having a webinar to discuss these procedural regulations with our commenters later this week. So these will be finalized in 2023. MHC is in the process of updating state health plan regulations for general hospital services to better align with the total cost of care model that's used to regulate hospital charges. Acquisitions of healthcare facilities are not subject to CON review and approval. We simply received notice about these changes in ownership. And this has become controversial because we've had a lot of turnover, especially in the nursing home area. So we are looking at the whole area of how these are regulated, and we anticipate there may be some recommendations coming in the future on that. And we're going to continue to consider ways in which the regulatory oversight of healthcare facilities can better address issues of equity and disparities in healthcare. That's a strategic priority that was recently adopted by our commission. That completes my presentation.
Thank you. You're blown away, right? Okay. Are there any questions? We are going to start with Delegate Johnson, followed by Delegate Rosenberg, followed by Delegate Woods.
Thank you, Madam Chair. Thank you for the presentation today. That was a lot of information. For our new members, could you explain the difference in a facility closing, like a hospital, that has a certificate of need versus being released from a certificate of need?
We do not require CONs for healthcare facilities to close. So that's not within the scope of the program. There are regulations that require timely notification prior to closure of a healthcare facility. And in some cases, there is also a requirement for a public informational meeting to be sponsored by that closing healthcare facility. That's intended to be an opportunity for the community to voice their positions on the closing of facilities and to hear about what transition plans may be involved in closing facilities. I'm not exactly sure what you mean by release from CON.
I know Harford Memorial Hospital applied for a release from the certificate of need, and we asked the Department of Health to put in an order with some parameters for them to close that hospital before they could close. So we were under the understanding that once released from a certificate of need, you could close with a 30-day written notice. Is that correct?
I believe the notification requirement for closures is 30 days. What happened in Harford County is that hospital applied for what is called an exemption from CON review. It's an alternative process to the standard CON project review, although it is a formal review, requires an application. and it also requires approval by our commission. But it's a review process that was established in law for hospitals, general hospitals, to transition to freestanding medical facilities. So that was a review that took place a few years ago, that was approved ultimately. So Hartford Memorial Hospital did obtain MHCC approval to close after development and opening of a freestanding medical facility. And in that particular case, I would also note that they also obtained a certificate of need, a regular certificate of need at the same time, to establish a small psychiatric hospital. And that's going to be on the campus of the freestanding medical facility in Aberdeen.
So just to add, I think that when you say release from CON,
And we only allow one answer. Sorry about that.
Nice try.
So, but I'm going to allow this just because you're answering him the question, right? So go ahead.
that the term release from CON might actually be turned, we don't use that, but it could mean conversion to an FMF. And that, both of you are saying the same thing. Hartford is now going to be converted to an FMF in Aberdeen.
Yeah, and before you answer, if you could decide who has the answer, that would be great. And for my committee, so that I am fair and equal, could you be so kind and direct the question to whoever you want them to answer it, okay? So next we have, that was Delegate Johnson, we have Delegate Rosenberg, followed by Woods, followed by Collison.
Mr. Stephan, you said on one of the recommendations regarding telehealth that this was the most debated and sensitive issue. Could you restate what the issue was and tell us why it is so sensitive and why you reached the conclusion that you reached?
I'll ask David to take this on as I think he worked through the work group issues. So go ahead, David. Sure.
Thank you, Delegate, for the question. The concern was whether or not that behavioral health providers, practitioners, would be able to continue to provide telehealth services remotely and not have a fail-first protocol where it only allows audio-only use when the technology, meaning a two-way communication where we're seeing each other through audio-video, does not work or has not been established. The behavioral health associations, the clinicians, were really adamant that the value of telehealth for behavioral health services comes in audio only. And the reason it does that is because it establishes protections that you would around privacy and security and confidentiality where it might call into question if the individual is audio video and has to be in a location that perhaps doesn't have the same level of privacy and security. The recommendation does call for, as noted, the continuation of audio only for behavioral health services. And that was a real important issue for the behavioral health community, both the consumers as well as the providers.
Madam Chair,
A quick follow-up.
who opposed it? Because you said it was so contentious.
So early on, there was debate from, as well as from different types of provider groups, as well as from the payers, and even some consumers. So it required some education, it required understanding of what the issues were, and then allowing for opportunity to discuss an approach forward that seemed reasonable to everybody.
Sure. We have Delegate Woods.
Thank you, Madam Chair. My question is also to you, Mr. Sharp, and thank you because it's actually a piggyback to Delegate Rosenberg's question. My question becomes, the protocols, are there protocols established where the visual assessment may be warranted, both in the behavioral health and the physical health for certain patients?
Great question. So let me start with the somatic care first, because the approach that was concluded with the input from the stakeholders and from the data was to have a fail-first protocol for establishing two-way audiovisual connection as the first line of using telehealth. And then if it was the provider, the patient, or just the situation where the telehealth encounter was occurring on the distance site, that it could go to audio only. It wasn't that the need to start with audio only first, but it is an option, and it was at the discretion of the provider, patient, and caregiver as well. On the behavioral health side, again, it gets back to the treating practitioner, but the practitioners seem fairly comfortable and encourage the use of visual as only you might say, a last resort, and allowing audio only as a preference for delivering care. That approach was far better received by consumers as well as the practitioners.
That's interesting. Thank you.
Delegate Collison?
Thank you, Madam Chair.
Pleasure.
So first of all, I have to say thank you. You guys do a wonderful job, and I feel like we are very prepared to make informed decisions. So thank you for that. Thank you for your willingness to continue to study telehealth. I'm very proud of what Maryland has learned through your work, and I think we're going to be making responsible policy ultimately about this new technology. So the question is, and I think this is for Mr. Sharp, as you study, continue to study the telehealth, one of the things that the carriers tell me is there needs to be specific coding for audio only and audio visual, because if we're actually going to study it in depth, we've got to make sure that we're, comparing the right things. So are we prepared to institute that level of coding, or how do you anticipate being able to make sure we're measuring audio only against audio only and audio visual against audio visual?
Thank you for that question. So the coding that's used to differentiate between audio only and audio visual exists. The real challenge, I think, what the providers and the carriers run into is its use. The carriers are a bit uncertain how accurate it is because the provider community is essentially learning its way forward, because as Mr. Stephan noted, prior to the pandemic, telehealth was hardly used. In fact, there were more advocates against using it than there was support for it. And then with the pandemic, everyone got comfortable. The question is around more for you're hearing from the carriers is around educating practitioners on appropriate coding. That is going to take a little time, but I think we're making progress in that direction. And the way our challenges here aren't much different than they are nationally, but coding is important, and that's part of the reason why additional study is needed to really understand what's going on in the claims environment.
Thank you, and I just want us to pay careful attention to that because I think we're going to need that in 2 years.
Yes, indeed.
Thank you. Thank you, Madam Chair.
My pleasure. Delegate White.
Yes, thank you, Madam Chair. This question I have is for Mr. Parker, related to a certificate or need around the approval and disapproval process. And so could you share any instances of where there may have been a disapproval, and what are some of the issues that may arise that may render that type of decision?
Well, I think the most recent disapproval, this was in the past year, is the commission did deny the establishment of a small psychiatric hospital on the west side of Baltimore for children and adolescents. And the basis for that denial was that we did not feel that they had demonstrated that it was a viable project, that it would be financially feasible over the long term. It was a contested case, so there were opponents participating in the review, opponents of the project. The commissioner who was assigned to review that project, and that happens when we have contested cases. It's not just a staff review and a staff recommendation. We actually have a commissioner who takes on the job of reviewing and developing a recommended decision to the commission. She actually found that there was a need for the project. So she was not happy to make a recommendation of denial, but she did not feel that they had the financial resources to really make a go of it. And we're expecting that to come back around, hopefully with an improved financial picture.
My pleasure. Any other questions? Seeing none, will you be so kind and address two things? Can you tell the committee how many commissioners do you have?
Sure. The commission is composed of 15 members. There are, the statute defines that geographic locations of commissioners. I'd have to get back to you on the actual, that part of the statute doesn't jump out at me, but representation is mandatory from the 5 largest jurisdictions, Montgomery County, Prince George's County, Anne Arundel County, Baltimore City, and Baltimore County. There must be a commissioner selected from each of those large jurisdictions. There then is a requirement that there be a representative from the Eastern Shore. Then we have some categorical requirements on commissioners that must meet certain occupations or provider categories. 2 payers, no more than 2 physicians. Consumer representatives, I believe we say that we have to have at least 6 commissioners that don't represent any provider interest. And then finally, a nursing home representative. Interesting that the statute does not require that we have a hospital representative, although we do have what I would say a quasi-hospital representative today. Commissioner Mark Jensen, who is a longstanding member of the Maryland Hospital Association Board, as well as MedStar is a commissioner today, but there's no formal designation that the governor appoint a representative from the hospital industry. I think that's more an accident of the statute when the 2 commissions were merged in 2000, that there was not a representative from the previous commissions. And I think that's somewhat of a limitation because so much of what we do in the area of health planning does engage the hospital industry. We've developed workarounds, and certainly we have robust work groups and where there's significant hospital representatives. More recently, we've also focused on ensuring that there's nurse practitioners on the commission, and I'm happy to say that we over the last 3 to 4 years, we've had very capable representatives from the nursing staff. Unfortunately, one received an appointment at an out-of-state nursing school to become dean. He had to leave, but we're fortunate that our newest commissioner is a nurse practitioner with expertise in drug treatment. We also have a new primary care commissioner appointed from Garrett County, who's very heavily engaged in all of the healthcare transformation initiatives, the MD-PCP program, as well as some of the programs that are offered through Medicare.
Wonderful. And how long are the terms for?
The commission is configured so that the terms are staggered at any 1 year. 4 commissioners are up for reappointment because of the rules related to the primary and a incumbent governor's term ending. We actually have 7 commissioners, I believe, that are eligible for reappointment or selection of an alternative this year. I'm not aware of any new appointments at this point, but I do know that the individual I mentioned most recently, Dr. Ojikutu, the nurse practitioner, had her appointment hearing on Monday night.
And are your meetings online?
Our meetings are, the meetings are held at the world headquarters of the Maryland Healthcare Commission, who happens to be in western Baltimore City, but they are piped in, and people can see them virtually, or you can retrieve the meetings through YouTube.
And your agenda is on the website,
The
correct?
website, the commission publishes a agenda, and it's typically available, the full agenda is available 2 days before the commission meeting.
And one last one last question before Delegate Hill's question. What is important for the work you do, as Delegate Collison said, is really important. For our members, will you tell them when we have a mandate, what is the preference?
So the commission thinks that the role that we have in assessing mandates is very important. And you'll see a common statement from the Healthcare Commission typically saying, this is an important service, but the committees need to be careful because any one mandate by itself may not add significantly to healthcare costs. And oftentimes there are very needed services that are being talked about in mandate legislation, but the cumulative impact on healthcare cost of many mandates cannot be discounted. So we try to give, on one hand and on the other hand, these are the issues that the committee must consider. Naturally, among the commission members, there are stronger positions against additional mandates among our health insurance representatives and more supportive positions among some of our consumer representatives. But I think there's a general consensus that we have to be cautious about adopting mandates as they cumulatively can increase healthcare cost and healthcare premiums.
Thank you. Delegate Hill.
Thank you, Madam Chair, and thank you, gentlemen, for your work and for your presentation. I just wanted to clarify, you went through the commission and you suggested that there was only one person who was peripherally representing a hospital. I thought, and just clarify for me, as you go through the numbers, there aren't at least 3 people who are associated as members or administrators in a hospital. There's only one hospital representation on the commissioners?
So there is no formal requirement that the governor appoint a hospital representative. And as I mentioned, Commissioner Jensen, naturally, virtually all the physicians are credentialed to practice at one hospital or another, but they're not employees of a health system per se.
Thank you.
Okay. Seeing no other questions, I want to thank you for the work you do for the state of Maryland, for the work you do when you issue these reports and you convene all the stakeholders, when you take our calls. Thank you so much. And for our members, they're really approachable. You have an issue, please call them. The reason why I asked the question about the mandate is that, a lot of times we want to support the bill, but we have to know what the impact is on the total cost, right? And they do that for us really well, and then we can justify doing it, whether it wouldn't be increase it by 50 cents or, $4. So it makes a difference as well. I just want to thank you for your time. As always, I appreciate your friendship and your work. You take good care. We have, our pleasure, we have in the audience some great visitors. Would you like to come forward and tell us your name and where you're visiting from? I know I'm putting you on putting you on the spot. Tell us who you are. This was not on the script, but I decided to do it. So tell us where you come from, your name.
Okay, my name is Avalyn Bennett. I am a senior at North Dorchester High School. I'm from Dorchester County.
So do you know, without that person moving, do you know who represents you?
Tom Hutchins.
Okay, wonderful. Well, welcome.
Thank you.
All right, can you tell us who you are?
Yeah, so my name is Alvaro Soron-Ruiz. I'm a senior at Eleanor Roosevelt High School in the gorgeous Prince George's County. So it's truly a pleasure to be here and serve as a state page this session.
And who represents you?
My representatives are Jazz Lewis, Tiffany Alston, and Drea Fletcher Harrison.
That's wonderful. Oh, we have two more. Why don't you come forward? Come forward. Tell us. We would like to know your name and what school and who represents you.
Okay.
Go ahead.
Hi, my name is Jaden Shiflett. I'm from District 32 in Anne Arundel County. Senator Beidel is my senator, and my delegates are Delegate Bartlett, Delegate Rogers, and Delegate Chang.
Wonderful. And are you a senior?
I am.
Beautiful. And how about you?
I'm also from District 32, so the same representatives, and I go to Meade High School.
Wonderful.
Oh, I'm Beckett Hummer.
And who's your mom?
Yes, a lot of you probably.
Becca, who's your mom?
My mom is Julie Hummer. She's on the Anne Arundel County Council.
Wonderful. So there's a
Emerge Class of 2021.
wonderful. So we have a question. Go ahead.
For the young man who attends Eleanor Roosevelt Senior High School, do you know who Sergey Brin is?
The excellent founder of Google, yes.
Do you know what you have in common with him?
I do not.
Sergey Brin's father, if I may,
Sure.
was a mathematics professor at MSU, not Michigan State, Moscow State. Wow. And Jews, the Soviets did not allow Jews to go into physics. So he was a math professor. And do you know who was the head? Does anyone here know who was the head of the math department at the University of Maryland, College Park 20-some years ago, 30-some years ago?
No, why don't you tell us?
Britt Kerwin, who later became the chancellor, recruited Professor Brin to come to College Park. And when they arrived, it was mother, father, and Sergey was, say, 7 or 8. And so he went to the public schools of Prince George's County and graduated from Eleanor Roosevelt High School before he went on to College Park in Stanford, where he met Mr. Hall. And you can look that up on Google.
I definitely will, the excellence out of PGCPS, so.
Delegate Taveras, 1 second. Go ahead.
Thank you for sharing that.
Alvaro has also been adopted by District 47, and he is somebody that I will tell you, as somebody who went head-to-head against him, he's a formidable candidate at the polls. We were on the opposing sides. But it was funny, too, because he is also a school board. So we brag about him. He's the first Latino to ever occupy the student board seat within PGCPS, and I know that he's going to have an amazing, bright future. So we're looking here to support him 110%.
That's wonderful. Well, I just want to say on behalf of the committee, I usually don't do this, but I wanted to welcome you and to say thank you for spending the time helping us on the floor and for being here. And you're definitely the future, okay? We're counting on you, and you have a blessed afternoon.
Thank you so much.
Thank you. And for the rest of the committee, we're going to take 15 minutes to set up into the next YouTube link, and then we're going to get started, okay? Thank you so much for your patience and for indulging me. 15 minutes, so it's actually 2:10. If you can come back by 2:25. 2:25. And there's food in the back, okay? Thank you. That was good. We're going to spend 15 minutes. Thank you for your patience. How are you? You're doing all right?